right? This is the biggest puja. If I can share something which will be useful for everyone for rest of their life, so even God will bless me from the top. Yes, this is a good work. Right? So what I was telling is, see, this pause for a moment and do this. I actually did this and I found that yes, it is so beautiful. Means you pause during that phase. What you have to really do is, it is called as the box breathing. Do the box breathing, right? Just for a minute, we'll do the box breathing. So all of you, just sit straight, right? It's very simple thing, but amazing. And do this thing whenever you start any of this your study. Right? Do it only for 1 minute and see the difference. So what you have to do is, you will inhale for the count of 1, 2, 3, 4. So this is in, right? For the count. I'll give you the count. And then hold for the count of 4, right? So count of 4 in, count of 4 hold, count of 4 out, exhale, and then hold for the count of 4. And this is what is called as the box breathing. There are several types of breathing. If interested, right, I'll keep on telling you about one breathing every day. There are certain breaths which will actually improve your cardiovascular function. There are certain breaths which will actually increase your strength, right? Physical strength, right? You'll be able to run longer distance. There are, I mean, you all are medical, you all are adult. There are few breathings which will actually improve person's sexual performance. There are certain breathings which will take you to transcendental meditation, that is to take you at a higher level, so that whatever you read once, you'll be able to remember it. Right? Many of the things, right, when we discuss with a non-medical, to even in one of my YouTube banned my video for that, right? Because it was about the intimacy between male and female, and that is so important, especially when it is said, right? And this is a fact. I said it in one of my videos of when we were discussing the pelvics. This was a survey which was done over 10,000, right? More than 10,000 plus females in India, over 16 cities. No names were taken, right? Means it was desire of person. If she says yes, so then the name was taken. Otherwise, no names, no nothing, no identity, but just a small questionnaire. And one of the question was that, are they satisfied? Right? This was ranging from 18 years to 48 years. This was such a big range. Right? And one was important. There were 7 questions. One of the important questions was that, are they happy with their partner? You'll be surprised. 78% said no. 78%, right? And then this number, this is like many of them, they said that we don't want to say. But this 78%, they were bold enough to say straight away no. So thus there are specific breathing, there are specific exercises, and those exercises, they are for male as well as female. So important, because say, being a doctor, you should be the fittest and you should be the finest at every place. Right? No doubt about it. This is vital. And see, as the life goes, right? One day, say, when you'll be giving birth to a baby, right? But that's not end of the life. At the same time, if your wife, right, when gives birth to the baby, it is like your responsibility to take proper care of her. And it is also the responsibility of every female to take proper care of herself. So many of the exercise, right, because this was, the name of the session was responsibility as a male. Right? Even this lecture was taken offline, but the worst part was, there were few elderly people and they said that, aap ye bachcho ko ye kya sikha rahe hain, वगैरह वगैरह, right? And then there was so much of chaos, and that they never allowed the lecture to continue. But the best part was the young generation. They said, no sir, please continue, because ye kaun sikhayega? YouTube pe it is like bakwas. I mean, there is so much of crap. So when you are a doctor, when you are learning it from the anatomical perspective, from the physiological perspective, right, your entire concept will change. So this thing, this box breathing, right, it is amazing thing for developing your focus. Right? This is for your focus. Just we'll try it for 1 minute, right? And then we'll start with our today's topic. And yes, we'll be finishing by 6:30, 6:40, just 1 hour. Because if you have understood this atrial septal defect properly, then rest all to it is so easy, so easy. Right? Automatically things will start coming in your mind. Okay, let's start. Right? I'll speak it like in, right, and then 2, 3, 4. Hold 2, 3, 4. Right? That's how I go. And you actually do it. Right? Actually, we'll be doing it only for 1 minute and see what happens. You can keep your eyes closed. Keep your spine straight. Keep your eyes closed. Whatever comes in your mind, let it come. Right? We are not telling that you have to speak any specific mantra or you have to stop thinking. It is impossible. Right? There are meditations, those meditations which will literally improve your performance in exam. Right? You'll be amazed at how fast and how sharp you are recollecting the things. Right? So these are some of the very proven, tested things. And you must have noticed one thing. I teach only that part which I have tested it on myself. Some things which are not successful, I'll tell you that also. They don't do this. Okay? But yes, say, if you say that, say today, the day before yesterday, we ran 21 kilometer, and then today we ran 10 kilometer. On this Sunday, we are planning to run, say, 32 kilometer, because just exactly after 3 weeks, right, one after the another races are coming up, right? One will be the full marathon, that is 40, then another one is 20 miler, that is 32, then once again a full marathon, then another race is of 66 kilometer where you have to run for the whole night, and then there is one super ultra that is for the 90 kilometer run, right? It is for the entire day, right? You have to cover the distance of 90 kilometer, whether it is धूप बारिश कुछ भी. So these are some very interesting pieces. I'll keep on showing you the pictures and the medals, right, as they are. But here is the breathing part, right? And when you will do that's what it is. When you will do it, whenever you start studies, right, any topic you want to study, before that just do it for 1 minute bus, right? That much. Let's start. I'm starting the timer now. In. Okay. First, just sit comfortably. Right. Ready? And how many of us have that? 22. Okay, no problem. Sufficient. Okay. Ready? I'm just drawing this. This box is already there. So let's start. In. 2, 3, 4. Hold. 2, 3, 4. Out. 2, 3, 4. Hold. 2, 3, 4. In. 2, 3, 4. Hold. 2, 3, 4. Out. 2, 3, 4. Hold. 2, 3, 4. In. 2, 3, 4. Hold. 2, 3, 4. Out. 2, 3, 4. Hold. 2, 3, 4. Relax. Now, if you have really practiced, this is what is called as the box breathing. It will generate such a beautiful rhythm, right? And it releases so many neurotransmitters. It releases oxytocin, it releases dopamine, it releases serotonin. All these are basically happy hormones. All are happy hormones. Right? So your ability will increase skyrocket. Okay, so let's start with our today's topic. And last time we talked about ASD, right? Atrial septal defect, and this was the amplatzer, which was for the occlusion of the septum. Any of the question, just keep on writing, right? I'll include during our discussion. Okay, so here it is, the ventricular septal defect. So that means now we are dealing with the ventricle part, right? So it is this part in which we are interested. Now this part is under high pressure system, because this is the left ventricle, this is the right ventricle. So here it is, this graph, right? This graphical image, what it is showing is that we are actually watching it from the right ventricle. We are watching from the front, right? So here it is, right? So this is the right ventricle. What if we remove this wall and we straight away wall? So that means this is the right ventricle, this is the left ventricle. So we are interested in watching this particular wall. And we have removed the front of the right ventricle so that we can really watch it. Right ventricle, from right ventricle, what will go out? From right ventricle, it is this pulmonary trunk which will be going out, right? So this one will be going out. And on the other side, on the back side, we have got the left ventricle. And from left ventricle is this aorta which will be going out. Makes sense? Right? So here is, and obviously this is our superior vena cava and this one is inferior vena cava. So this is the right atrium and our right ventricle will be on the back side. Perfect. From right atrium, this would be the outlet, and for the right ventricle, this one would be the inlet. Correct? This would be the inlet septum. So can we really say this one would be the inlet septum? Correct? Inlet septum. So from right atrium to right ventricle, there goes, right? This is the area from where the blood will be entering into the right ventricle. So this particular thing, first one, right? Because these are the various names. So this first one, this one, that area, if there's, because see, this entire thing is septum, and there can be a defect anywhere. Right? There can be defect anywhere. So if the defect is over here, where I have written 1, so that thing is called as the peri. Peri means near, right? This structure is membranous. That means it is quite thin. So perimembranous VSD, right? Near the inlet septum. That means where? Near the tricuspid wall. Correct? Near the area from where the right atrium to right ventricle things are going, blood is going. So it is this area, that is where we'll be calling it a perimembranous ventricular septal defect. So this was easy. So in other words, perimembranous VSD means where? We'll write for our understanding, near inlet. Near inlet, correct? Where is the outlet? Outlet is where it goes into this pulmonary trunk. So that's the outlet. Correct? That is the outlet. So if the defect is over here, I mean in this entire area, right? So if the defect is near to the outlet septum, so then we'll be calling this thing. This is pulmonary trunk is the artery, big artery. And this defect is just underneath the artery. So we'll be calling it subarterial VSD. Right? How easy it is? Right? Because if someone tells that what are the types of VSD, and then it is said that perimembranous VSD, subarterial VSD, and the trabecular septum VSD, then we find that it is so complicated. No, it is very easy. Right? Inlet, and this is near the outlet. So now 2 things we have cleared. Now this is the third area, this one. Right? I'm writing 3 almost everywhere. This is the area. This area will be superbly muscular, you know? Because that's the area, right? You can see the muscles. So this one will be the muscular area. Muscular area. So muscular is a layman word, right? Muscular is like a layman word. We say that muscular, they are because of the trabecular, right? Trabecular. See, these are trabecular. See these. These are the muscles. They are called as the trabecular. So trabecular, what if we use the, instead of muscular, we use the word trabecular? Basically, for understanding it is, so it is quite thick area, right? So trabecular or the muscular area or the trabecular VST. So that's the third type of VST. So these are the three types. Yes, you need to know these three types. So first is what is called as the perimembranous near inlet. Second is the subarterial underneath the big artery pulmonary trunk, right? And the third one is the trabecular VST, and that is the thickest portion. Fine. So here it is. That's the IVS, interventricular septum. Now see the size. This is because this is a real specimen. See the size of the interventricular septum. Such thick substance, right? And when there is hole in it, so it is not easy to occlude it. Plus it is under high pressure. Okay. Meantime, this is the right ventricle. From right ventricle, there goes the pulmonary trunk. This is the left ventricle. From left ventricle, there goes the aorta. Right? This is right atrial appendage, and this is the left atrium. Right? Just like a cut section. Okay. Easy to understand. This is just a diagrammatic representation of the ventricular septum defect. Right? Here to here. Right? This one is the left ventricle, and this one is the right ventricle. This one would be the right atrium, right? Superior vena cava and inferior vena cava. This one would be the pulmonary trunk, and that's the arch of aorta, correct? And then this one would be the brachiocephalic trunk, that is left common carotid, and the left subclavian, and it continues. This defect which is shown over here. This defect is not over here, because if it is over here, then we'll be calling it subarterial. If this defect is lying somewhere over here, so then we'll be calling it perimembranous. But because it is right in the middle, this is the area where there is so much of muscles. So that's why this one would be the trabecular or the muscular, right? So trabecular VST. Correct. Let's move on to this. Yes, you can ask questions at any point. So this is today, right? This one is today. In which ultrasonic waves are used. Yes. So already right ventricle, left ventricle. So this one would be the right atrium. This one would be the left atrium. This one is the mitral valve, correct? And this one is the tricuspid valve. These valves are fine, right? They are forming very proper. This is the defect. That's the defect. This is the defect. Now, just from this, immediately we'll be able to say that this is nothing but it is the low trabecular, or you can say muscular VST. Because that if the defect is over here, so then we'll be calling it perimembranous. Right? If the defect is when it is exiting, right? Because in this section, so we won't be able to see because everything is round, right? So from the chamber, the area from where the pulmonary trunk is going, and there the defect is, then we'll be calling it subarterial. But this trabecular, this is the commonest. Right? This is the commonest, and I'll show you some very typical cases. So this is the commonest. Now, though this is very rare, this particular thing, but sometimes it happens. This is what is called as the multiple muscular VST. Right? Multiple muscular VST. See in this, right? See the defects. As if the whole wall, right? Whole wall, here, right? This time. In this case, occlusion would be very difficult. And occlusion is difficult. You can't occlude it with amplified set because of this entire structure. See, in reality, though this is a case from the museum, right, from one of our specimens, but this is how it looks like. See how many holes there are. How will you fill them? And that's why there is a name which has been given to this. This is what is called as the Swiss cheesecake appearance, or the cheesecake VST 22. This is a pattern. See, this is the 2D echo, very similar. This is how it looks like. Now you'll be able to identify very easily that this is the wall, and see these are the gaps, these are the gaps, these are the gaps. So all those arrows marked there. This is the multiple VSTs. All these type of cases, they are for study. So this is once again 2D echo. Can AST and VST exist at the same time? Good question. Yes, they can. But usually, you'll find that AST is more common. But yes, definitely, there are cases when AST and VST are existing at the same time. And it happens like when we'll be going into more detail, like next time when we'll be going for the congenital heart disease part 2. That is basically, it will be about the cyanotic heart disease, not acyanotic. Acyanotic we discussed. When we'll be talking about acyanotic, or we'll be talking about cyanotic, that is when the baby will become blue. So in that, you'll find that not only ASD, VSD, but so many other things also they change. Right? The big vessels, transposition of great vessels, the vessels itself will start changing. Right? Some will become narrow, some will become big, right? All those things. So there you'll find that those babies, they usually don't survive long. But yeah, ASD, VSD, they can exist at the same time. So here is one another X-ray, and in this, with current experience, within seconds, first thing which you'll say is that the heart is 100% enlarged, massive, right? So there is massive cardiomegaly, correct? The heart is enlarged. That's right, cardiomegaly. Right? Then another thing is, say this is the left heart border, correct? That's the left side. This is the left side. Left heart border is always very graciously like this, right? But over here it is straight. So this is a very important finding. It is what is called as the straightening of left heart border. Now from today's session, even if you forget everything, no problem. But when this thing comes, never ever forget. Whenever you pick up any of the X-ray, right? Apart from lung fields, right? When it comes to heart, and if you see there is cardiomegaly, first thing you will see is whether the left heart border is straightened or not. Because if the left heart border is straight, it is a clear indication that there is left atrial enlargement. And the very next question, if the patient is there, what question will you ask? Let's see, the patient is there, right in front of you. Right? You are in OPD, right? Technician has come, that madam, just see the X-ray, you see that it is enlarged. Patient is there, you say, where is the patient? What first question will you ask? What would be the first question when you see this X-ray? Right? This is to be of a kid, but even if it is of adult, when you see straightening of left heart border, what would be the first question? Left atrial enlargement leads to what? Which other structure is very close to left atrium, which gets compressed and can lead to some problem? Arey bolo. I'm waiting. I don't believe it. Not a thing. हाँ, So that organ, but what question would you ask, my friend? Deepnika, Man, and Heer. All of you wrote esophagus. Huh? Man, it is esophagus. Exactly. That's the thing. Do you have any difficulty in eating, swallowing? Swallowing, right? So that is what is called as the dysphagia. In clinics, when you will go, this X-ray would be shown to you, and it will be asked that patient will be having, what would be the, usually patient will come with what symptom, and your answer will be dysphagia, difficulty in swallowing, right? Because this is the thing, this is the left atrium, esophagus is over here, esophagus is easily compressible. When the esophagus is compressed, when the person will try to swallow, right, he has to strain, and then the things will go. Because as the condition deteriorates, dysphagia becomes bad and bad. Got it? Great. Okay. Now, so this is one. So meantime, here is the border, right? Normal border. When the left atrial is enlarged, left atrial, which is Sita Sada, hidden behind, this is the left atrium. But when it is enlarged, so its shadow will come over here and it will obscure this thing, and thus we will be getting a straight heart shadow. This is what we get. This is what is called as the straightening of the heart border. Another thing, if I just zoom it, and I would really appreciate if you can say something about, right, something about the lung fields, right? I'm not giving you more hints, but these are the lung fields. Do you see anything? अरे मेरे दोस्त, middle lobe consolidation नहीं, अभी just see for the lung fields. Lung fields. Watch only this much field. That's right. That's right. That's right. Durgesh, you are right. No, maybe me. Yeah, that's right. No, maybe me. Curly B lines, right over here. So yes, there are in fact curly B lines. But what is the common thing first? Common thing. Only two answers still. What was taught to you? When you see the lung fields, you have to look for what is BVN. That's right, Ruchita. BVN, right? Bronchovascular markings. So bronchovascular markings, they are prominent, but what would you really see that? Bronchovascular markings, they don't cross the outer. They are not present over here. The outer 1/3, they are not present. Yeah, right? Over here, the Bindas, it is seen till end. Right? It is seen till end. Right? Correct? See? Remember? Right? Seen so clearly on both the sides. Right? Here it is. So here, the bronchovascular markings, they are seen till end. Right? So normally, now whenever you check this out, right? See? Right? So there is prominent BVM. So when it is written prominent BVM, that means what? That these markings, because no radiologist would write that bronchovascular markings, they are seen on the outer one. Yes, they will write exactly like prominent bronchovascular markings and write it with proper. Yes, you are right. Prominent BVM. So that means they are presented to outer 1/3. So this is the thing, and this is because there is left to right shunt. Right? There is left to right shunt. If there is left to right shunt, and if the question first it is asked, is there Eisenmenger complex? Do you see? Will you be telling that is there Eisenmenger complex? I hope you remember what is Eisenmenger complex. Eisenmenger complex is that as the pressure increases, right, there is increase in the pulmonary there is pulmonary hypertension, increased pressure into the pulmonary system. It increases so much so that there is reversal of the shunt, and now the blood goes from right to left, right? So over here it would be from right ventricle to left ventricle. When it goes, that is called as the Eisenmenger complex. In this case, because as soon as the Eisenmenger complex develops, bronchovascular markings, they disappear from the outer 1/3 because the pressure is bit relieved, right? Because the blood is now getting pushed onto the opposite side. So whenever we see this pattern, right? So that means there is no Eisenmenger complex. There is no Eisenmenger due to VVM in periphery. Perfect. Very right. One question which we might ask is that when we have got the left to right shunt, so then why the left atrial enlargement? Right? Why the left atrial enlargement? Very interesting. What happens is this. This is the left ventricle. Large amount of blood is pushed into the right ventricle. Large amount of blood. Now, the amount of blood which was getting pushed from the AST, that was far less, because usually ASTs, they are smaller. When it comes to VST, then VST, not only they are bigger, but sometimes they are multiple. Right? So when it happens, the large amount of blood is getting pushed, when that blood will go into the pulmonary trunk. From pulmonary trunk, it will be routed to the lungs. And lungs will try to fill that thing over here at a much higher pace. So thus there would be left atrial overload. Right? Left atrial overload. So that because of this left atrial overload, there would be left atrial enlargement. Now the question which might be asked is, so what about the right ventricle? Will not that be enlarged? Right ventricle will be hypertrophic. So thus we get this type of picture. The big heart, because right ventricle is enlarged, at the same time, right, the left atrium is also important because it is getting overloaded, right? More blood is coming. Yes, watch this. Right? Straight away, the moment you look at immediately, you say it is of baby. So clearly, beyond doubt, certain things, straight away say cardiomegaly, right? Cardiomegaly, heart is enlarged, no doubt about it, such big, right? Straightening of the left heart border, because this is not like this. This curve is gone, right? So I'm writing, say, left atrial enlargement, correct? Third thing, very good. I was about to say this bulge, right? Horrible bulge, right? Otherwise, the heart is like this, right? So over here, it is becoming like this. So that's right. You are very good observation. That is the right atrial enlargement, right? It should be close to cubic. That's right. So this is enlarged, and no doubt about it. Even from this distance, you can see that BVMs, they are prominent, right? Prominent BVMs, bronchovascular BVMs. Right? However, if we just zoom this thing, right, this is a very typical case. See, over here, bronchovascular markings almost they are going till the end. But if you really see this side, right, this side is clear. This side is clear. The bronchovascular markings, they are ending up this level. So this is like beginning of the Eisenmenger complex. Right? Over here, right, it is clear. So therefore, beginning of Eisenmenger complex. That's why it is necessary to see the things on both the sides. Okay. Obviously, patient is in ICU, right? All these tubes and everything everything is put, all those proofs. Yeah, this one. Over here, this arrow is indication of one word. One word is but this prominence like this. Last time we learned it is because of the main pulmonary artery which is prominent, and there is a word for it, and it is called as the pulmonary. We complete it. Pulmonary, right? It is because of prominent pulmonary artery. It is called as pulmonary conus. Got it? Pulmonary conus. Because over here, if you see the lung fields, they are quite clear on the. This is the already initiation of heart is enlarged. Right? Definitely, heart is enlarged. It's a big one. Because if you consider this thing, this distance as B and this one as A, then definitely B is more than half of the total width. Right? This is the development of Eisenmenger complex. So see the peripheral lungs, they are completely clear over here. Here, though, they are totally clear. Right? Over here. Let us remove this thing. And I just put small arrows. Right? Writing clear. So later on, when I send this file, we will be able to zoom and see. So this is the Eisenmenger complex beginning. Or in fact, it is developed. Not beginning, it is developed. Right to left shunt has already started. So here, this is what we were talking about, that this is the amplexer. This amplexer is called as the amplexer VST occluder, ventricular septal defect occluder. The characteristic is this middle portion will be thick, and both the sides, right ventricle and left ventricle, right, they are of the same size. If you remember, in case of AST, the right atrial side was smaller, right? So this was the shape of it. Right? So this was for AST, and this one is for VST. And another thing is that because the AST, the thickness of the wall of the interatrial septum, that is thin, so that's why this is thin. Over here, the wall is thick, so that's why the middle portion that is thick, because IVS interventricular septum is thicker. So in case of hemodynamics, right, initially VSD allows left ventricle to right ventricle shunt, right? Nothing new. So that left ventricle to right ventricle and causing pulmonary artery, yes, because the pressure is increasing. Right? So here it is the left ventricle to right ventricle. From right ventricle, the pulmonary trunk, right, it is going out. So that pressure will be transmitted to the pulmonary artery. So that pulmonary artery, that is dilated. That blood, the amount of blood that will dump into the left atrium, right, and then that blood will go to left ventricle. So that's why you'll find that left atrial and left ventricular dilatation, that is seen. But important thing is pulmonary hypertension. Yes, pulmonary hypertension, it has to be there, right? And pulmonary vascular obstruction, that is the Eisenmenger reaction when the pressure increases. In case of Swiss smear, do we put multiple amplexers? No, we can't put, because there is no such amplexer, multiple amplexer, right? So at times you have to really repair, you have to do the surgery, you have to really repair the whole thing, right, by putting a flap. So right to left shunt, systemic desaturation, and then there is cyanosis. Right to left shunt. Over here, the cyanosis will develop faster, because from the right side to left side, that is the deoxygenated blood will be going into the left side, and that would be circulating into the entire body. So complications of Eisenmenger reaction, they eventually occur. Small VSD does not cause any symptoms. If it is very small, it doesn't matter. Large VSD causes symptoms of congestive heart failure, right? Because it is the right side, right heart overload. The right heart is overloaded. such as poor or small frequent feeding, failure to thrive, tachypnea. Now, I'll explain all of it, right? Small or frequent feeding. One, feeding is difficult because when that little baby, when they try to drink, right, because the esophagus will be compressed properly, right? Good blood, that is oxygenated blood, is going on to the right side. So basically, the body will be deprived of the oxygen. So that is less. Tachypnea, what heart will try to do, what the brain will do. Brain will say, there is less oxygen to the tissues. Beat fast, heart rate will increase, right? Frequent respiratory infection, because that oxygenated blood is not reaching everywhere, right? It is in fact the mixed blood which is reaching everywhere. So chances of infection, and plus the congestion is there. So congestion, that will lead to frequent infection. Fatigue, less oxygen, so definitely baby would feel fatigue, and dyspnea on exertion, less blood, less oxygen, right? So that's why problem whenever there is any exertion. As Eisenmenger reaction eventually occurs, patient develops symptoms and complications of Eisenmenger reaction, like what we talked about. Remember, we discussed all of them, right? The next one, this is the patent ductus arteriosus. Patent ductus arteriosus, this is pulmonary trunk, right? And here is the artery, aorta. It is this gap. That is what is called as the ductus arteriosus. Now, in ductus arteriosus, it is a duct between two major arteries, right? Duct between the pulmonary trunk and the aorta. Why it was necessary? Why it was necessary? Because before birth, whatever the blood which tried to enter into the pulmonary artery, but they were knowing that there were no lungs, but still some blood, some smart blood, it entered into the pulmonary artery. So we should not be wasting this blood which has entered into pulmonary trunk, and that is pushed into the aorta via this ductus arteriosus. Right? This ductus arteriosus is kept patent by prostaglandins. All these are questions by prostaglandins, right? Prostaglandins, they come from placenta, right? So when the placenta is removed, this prostaglandin is not there, so this ductus arteriosus shrinks. There is no pressure thing, like say foramen ovale, right? Foramen ovale, it gets closed because of the pressure. So we have got one flap over here, and there is other flap which is over here, septum secundum and the septum primum, right? So as soon as this side is the left atrium, as soon as the pressure increases, the blood tries to go, this stops, right? And then it will remain over there, and then the fossa ovalis would develop. So that was the pressure, but this remains open, and that's why initial days, sometimes you'll find that the baby is pretty silent, right? And the blood which is going from the aorta, it actually goes into the back, right? This is the reversal of shunt, which remains for few days and then it automatically gets resolved. So this is reversal of shunt, temporary reversal of shunt. Right? The question is asked of the temporary reversal of shunt. Here it is, this is a real specimen, and that's how it really looks like. Over here, this is the main pulmonary artery, and this is the arch of aorta, and we can see a very big, right? This one. Right now we can see it over here. This is pretty big. Those star marks, right? Pretty big patent ductus arteriosus. Right? It has to be, say, closed. If in case if it is open, it has to be closed surgically. Here it is. This is a real patient. And this is the aortography. Right? This is DAO is descending aorta. Right? And not a big rocket science, even from the looks itself, you can see that that's the aorta which is going all the way down. Right? So this is the aorta which is going all the way down. This one is the main pulmonary artery. So when we introduced a catheter, right, and the dye is injected, that dye is going into the aorta, right? The dye is going into the aorta. It should not go, yes, but it is going. Right? And here it is the display. Out of many of the plates, this one, this is the patent ductus arteriosus. This is long and tortuous. PDA. Patent means it remains open even after the birth. In order to shut it, right, because it is necessary, there are two methods. One is the detachable coil for small PDA. This is like a coil. When it is introduced, right, so that coil goes round and round, and if it is small, then as soon as it gets squeezed, right, it would be forming all those fibers and it will stop it. Right? Stop. If it is bigger, then we might have to go for the amplexer duct occluder. The speciality of amplexer duct occluder is that only on one side, so its shape would be like this, right? For the ASD, it was sort of, it was like this, right? This one was smaller, this one was bigger, and it was like this. For the VSD, it was like this, and thick one, and this. For PDA, it is like this, and this. That's how it is. That is for the duct. So initially PDA allows left to right shunt, makes sense, because the pressure in the aorta is much higher. So left to right shunt, causing pulmonary artery, left atrium, and the left ventricle dilatation because of the pressure. However, if a large PDA remains open, there would be pulmonary hypertension because it has to be so large so that large amount of blood should really go to cause pulmonary hypertension. Usually this is not seen. Commonly it is not seen. And pulmonary vascular obstruction, so that there is development of Eisenmenger reaction, so that there is right to left shunt via that patent ductus arteriosus, and which is leading to systemic desaturation, cyanosis, and then the complication. This is rare. This is pretty rare. Well, in this case, in the case above, this is a case of which Eisenmenger complex developed, because this is unusually large and tortuous patent ductus arteriosus. Usually it is not that. So all those complications of Eisenmenger reaction, right, which were there, one of the commonest was that patient develops cyanosis, right? Do remember this. Patient develops cyanosis in this one, right? Then there would be the polycythemia. Polycythemia means there is increase in the RBCs, red blood cells, right? They increase. And that thing can lead to stroke because the clot formation increases because of increased tendency of clot formation. When we'll be learning blood, at that point we'll be learning several systems that why this clot forms, right? How the clot forms, in what area, what leads to all of them. Then the commonest is right heart failure. Right? When there is right heart failure, so then what will you develop? Discuss it into the respiratory. Right heart failure, that means there will be swelling, right? There will be swelling in the feet. And that swelling would be like, there will be pitting edema. So if you really press, you'll find it can be cut down, right? So that is there. Then fourth is, when this thing occurs, there would be atrial fibrillation, right? Eisenmenger complex, atrial fibrillation. Atrias, they start beating faster. There would be mitral regurgitation, tricuspid regurgitation, where the valves are getting affected. Then because of the pulmonary congestion, there would be frequent upper respiratory infections, right? That would be, this is how many times patients will come with this, and if not treated well, then when that death can occur. So this is the order in which you must develop. This is very important question. Many times it is asked also, and good to know. On to the coarctation of aorta. When it comes to coarctation, coarctation means narrow. बस इतना समझो. Coarctation means narrow. So where exactly are we talking about? So here is the aorta. Right? I'm drawing aorta in 2D. Actually, you know that the front part of this is the ascending aorta. Ascending aorta is in the anterior, right? And the descending aorta is into the posterior mediastinum. So it means the aorta, it actually goes like this, right? If it starts over here, so then it goes like that. It goes back, right? That's why over here there is spine. So when we'll be learning CT scan, right? We'll be learning CT scan and we see the spine over here, the structure which is round, big, thick structure, yes, that is the aorta, right? And if it is section is taken at this level, one like this and one like this, yes, this is the ascending aorta which is into the anterior mediastinum, and this one is the posterior mediastinum. This is the descending aorta. First, it takes turn. Now, over here, right, so this is the location. In between is the arch, and from arch, right, over here, it would be the brachiocephalic trunk. From brachiocephalic trunk, one branch will be going up, and that would be the right common carotid artery, which will be supplying to the brain and the head and neck. And this thing would continue as the subclavian, right? And it is the subclavian which will be supplying to the upper limb, right? I mean, this is the right side, so it will be supplying to the right upper limb. From here, it would be the up, it goes the left common carotid artery, and this one would be the left subclavian artery. Why we are discussing? Because there are two types of this coarctation of aorta. That is the narrowing. Right? We talked about narrowing. So which another vessel was over here? Well, it was the pulmonary trunk. Pulmonary trunk. This one is the pulmonary trunk. So everything revolves around that there are two types, infant type and the adult type. Infant type and the adult type. It can occur in both. Now in infant type, right? In infant type, the narrowing is after aortic arch and before ductus arteriosus. So this is aortic arch. This one is the arch, right? And let's for our understanding, right? So I'm drawing. So here it is, and let's say if this one, this is our ductus arteriosus. So narrowing is after aortic arch and before ductus arteriosus. So this would be the area of this one. The artery would be narrowed like this. This one is coarctation of aorta. So narrowing will be there after aortic arch and before ductus arteriosus. So here it is the ductus arteriosus, this is the arch, and in between we have got the narrow. So that means this whole tube, right, will narrow and then it will go once again. So what do we expect? Will there be any trouble to the head and neck and the upper limb? Absolutely not. Because head and neck, that is getting the blood supply from common carotids. So common carotids, they are with us, right? Straight away they will go. Subclavians, yes, they are going happily, no problem. Whatever the organs or whatever the area which will be suffered, that will be below this, right? So it is the abdo-pelvis. They won't be getting sufficient blood, right? Because it is going through a narrow space. Yes, exactly. Lower limbs, right? Lower limbs and the abdomen and pelvis. So they will be suffering. Reason? Less pressure. Right? There is less pressure. That's the trouble. So when this thing occurs, very easy. You take the pulse, lower limb pulse, and you find that yes, there is difference. So symptoms: lower extremity cyanosis, right? And it is present at birth, and it is easily seen, right? Seen easily. So as soon as the baby is born, just look at the lower limb, right? And because their skin is very delicate, very thin, and the moment you'll see that it's bluish. You compare it with the upper limb and lower limb, you'll find the marked difference in the color. So this is one simple observation and you'll be able to. They often do not survive if not operated immediately. They do not survive. And another thing is, those who survive at a later stage, right, they may suffer. You'll find that they are many times associated with Turner syndrome. In Turner syndrome, this is a female with XO. XY or XX, but it is having one missing. So that's why there will be so many changes into her characteristics. Right? When we'll be discussing endocrine system, we'll be talking about this in more detail. But this particular female will be losing some of the feminine aspects. She will become a bit like male, right? Because one of the, yes, rudimentary, so many things, hirsutism, rudimentary ovaries, right? The breast will not be developed. She will be more like a male, right? Malish characteristic. So all those things, they do occur. In adult type, there is no ductus arteriosus, right? So there is no mixing of blood. Right? Oxygen, carbon dioxide, there is no mixing of blood. So it is just the narrowing, right? It is like the narrowing, right? The duct, this aorta is there and it is the narrowing. Right? Previously to what was happening, the ductus arteriosus was also there. So due to that, the pressure, right? Because here it is a narrow, this is narrow. So blood was going over here, right? And unnecessarily it was affecting everything. But now, in adult, there is no ductus arteriosus, so there is no mixing of blood, nothing, all good. But it would lead to what? It will lead to upstream situation. Now, upstream situation is, I'll explain it over here. Upstream situation is, here there is narrowing. Right? Now, this is an adult. Right? This is narrow. So, there would be rise in the pressure over here. Right? Because it is what is called as the back pressure. And it is called as the back pressure. So, that back pressure will start going up. Now, where it will be affected? To those areas which are most delicate. Right? They are the most delicate. And in that case, it is the upstream situation. This is what is called as upstream. There is increased pressure in upper limb head. Right? And that leads to what's called as the Barry aneurysm. What Barry aneurysm is, that all those small vessels, right, they develop. This is what is called as the aneurysm. Aneurysm means here is the artery. Right? Artery has got thick walls, right? Nice thick walls. When there is weakness in the wall, this artery, this wall, it bulges. It bulges. So this is a potentially weak area, right? And that weak area, it can rupture. And once it ruptures, there will be extensive bleeding, which is usually fatal. Right? So that is what is called as the aneurysm. Aneurysm means weakness in the wall of blood vessel. Correct? Blood vessel. Barry aneurysm, that is what is seen into circle of Willis. Now, what circle of Willis is? Say, in our, say this is the, consider this is the brain, right? So from brain, I'll show you it this way. Here is the, right? Here is, this is brachiocephalic, and here is the common carotid right, common carotid left, right? So they both are going up. Right? From common carotid, there is external and the internal carotid artery, internal carotid artery, internal carotid artery. Right? Those internal carotid arteries, they enter. Then there are vertebral arteries which will be arising from here. So those vertebral arteries, they go backside. Right? So here is the vertebral artery, here is the vertebral artery. They both combine together, right? And they form what is called as the basilar artery. Basilar artery. These are the vertebral arteries. And this basilar artery will divide. Similarly, this one will also divide. And right now, I'll not confuse with, but these are all anterocerebellar, metacerebellar, posterior cerebellar. These are the posterior cerebellar. Then there are cerebral and then there are some cerebellar arteries, and then there are anterior communicating artery, but they basically form the whole circle. They form the whole circle. This is the circle which supplies the brain, and that is called as the circle of Willis. Circle of Willis. So, but you have understood one thing, that it is this vertebral artery and the internal carotid artery. So thus brain has got such a rich blood supply from both the sides, right? Internal carotid, they divide, then from the back side, right? Vertebral goes, and then it forms one artery, that is basilar. Then basilar divides into the posterior cerebral arteries, and then the posterior communicating, and it forms this whole circle. And then they supply to all deepest areas. These are delicate areas. Aneurysm, they develop into this, and that is Barry aneurysm. Barrys, right? They are very small, right? Very small. So here, this is what really happens. That delicate artery, and then its wall, they are easily bulged because of pressure. Right? Same thing happens when there is increased blood pressure. People say, "Sir, phata ja raha hai." What is that? Why it is necessary that one should not be angry? Because when one becomes angry, there is increased blood pressure. And that blood pressure, because heart is beating, right, we're throwing the blood with power, that entire thing comes to head. It comes to the circle of Willis. And these are very delicate. When I'll show you all those arteries in the real dissection, you will be surprised, so delicate, right? So that when they rupture or when they get bulged, that is what is called as the Barry aneurysm. They are dilated. Another thing, right? So this is Barry aneurysm. There is aortic dissection. Aortic dissection means here is the aorta. Here is the aorta, very thick, right? So right from the beginning, we are telling that we are proud of you, aorta, right? Such a thick wall and very powerful. Everything said and done. But finally, though, it is a soft tissue. When the blood gushes, right? When the blood gushes, it actually peels one of the layer, right? And the blood tries to enter into this place. Because that internal wall, right? It breaks, the blood tries to enter. And when it enters, it literally, as if it is breaking, right? This blood is going with the pressure, so that wall, it keeps on getting damaged. This is what is aortic dissection. It's fatal, right? Similarly, aortic valve, high pressure, aortic valve is bound to get affected. All these things because of the upstream pressure. Then remember, what we have to remember is everything occurring before that, right? So over here, so in upper limb, right? Upper limb, head and neck, brain, right? All are affected. Aortic valve is affected. So this is the upstream. What about the downstream? Totally reverse. In the downstream, there is decreased pressure in the lower limb. So when you take the pulse, it will be very weak pulse, right? Weak pulse. Second, claudication. Claudication is, as such, person is fine, but when person starts walking, starts developing severe pain in the legs, right? So this is pain on exertion. Now this makes complete sense, because when you start running, when you start walking, there will be large amount of blood which will be coming to the rescue of muscles. Muscles will be demanding. So muscles are demanding nutrition as well as oxygen. But here the pressure itself is low. Body is not knowing. Body is keep walking. Body is demanding, give me more oxygen. When there is no oxygen, there is less of the nutrition. The pain receptors would be activated. Why? Because it is our defense system. It will tell, don't walk, right? It will say, don't walk. So that pain is a defense mechanism that gets triggered, and that is collectively called as the claudication. Claudication. Decreased kidney perfusion. This is one of the worst thing. This is perhaps the worst thing. Why? Because here are the kidneys, right? Here are the kidneys. This is the aorta, the descending aorta. From there, the renal arteries, they are going inside. Inside our kidneys, there are pressure receptors. They will be telling us blood is coming with such a slope, right? It means the blood pressure is less. raise it, right? That's what kidney will be doing for the bhalai. If there is decreased pressure, so because the pressure is low, is not understanding pressure is low right from the top. No, kidneys will say, we don't understand. Less blood is coming, so that kidney perfusion means amount of blood which is given to the kidneys. So kidneys are getting less blood, so they will, this is RA, it is called as the renin, angiotensin, aldosterone system, right? Aldosterone system. So this is a whole system, angiotensin 1, 2, right? It comes from lungs, all that mechanism will understand. But this is the mechanism. I think we have even discussed it when we were discussing the blood pressure. Anyway, so this is the system. It will say, let's squeeze the arteries. There is no need to keep them dilated, so they will be squeezed. Because when they will be squeezed, that means there is less space. So now they will say, yes, blood pressure is fine, but it will affect the entire system and there will be hypertension. Right? There will be hypertension. So this is the thing, where kidneys, they will misinterpret this blood pressure. Treatment, balloon dilatation. Wherever there is narrowing, right? If this is the narrowing, then you put that balloon, right? That balloon is put, and initially it is deflated, and then you just inflate it. So with the pressure, this is made up of normal caliber. That is called as the balloon dilatation. If it is not successful, you might need to go for the surgical correction, right? Which is a major surgery, because stent is what? Right? This is basically like stent, you know? But when it is stents, they are usually very small. Here we are talking about aorta. Stent, they are put into coronary, right? Coronary arteries. So stents, they are pretty small, right? Because that's the coronary caliber which you have to negotiate. But over here you are talking about aorta. And when this surgical correction, it is easy to write. But remember, it has to be done on the aorta, which is under high pressure. So much of blood is getting pumped, right? So the whole heart is slowed down at a very slow level, right? Heart-lung machine is involved. The blood is bypassed, corrected within stipulated time, and the whole blood once again goes on to the normal, right? I'll show you even all those steps also. One of the very fine thing which you need to see, this is a super classic adult, right? In order to understand this thing, we draw a small piece of anatomy. Here is what? This is our aorta, correct? And from aorta, this is the subclavian artery. We are talking about the right side. From subclavian artery, right, there goes, right, one major artery. That is what is called as the internal thoracic artery. Right? This is one artery. I'm drawing just simple line, otherwise it is pretty big. And from this internal thoracic artery, there goes anterior intercostal arteries. Now, intercostal, immediately it will strike you. Intercostal, right? Intercostal will do what? Intercostal is that these are the ribs, right? These are the ribs. And in the ribs, in between the ribs, this is the intercostal space, correct? Intercostal space. And right from the beginning, we are telling that it carries vein, artery, nerve. Where is it? The vein, artery, nerve bundle is always onto the lower side, right? This is where the vein, artery, nerve is, right? So you know this part. So that means with every rib at its lowest, at the lower end, there is a bundle, vein, artery, nerve. In fact, when you see the rib, there is a notch, right? In that notch, very safely, vein, artery, nerve, they are going. So far, all okay. So this is in which we are interested, anterior intercostal arteries. Now we add one more thing. These are the anterior intercostal arteries. What about the posterior intercostal arteries? Posterior intercostal arteries, they emerge directly from the aorta, right? So this is posterior intercostal arteries. You will be so happy to understand this the moment I'll show you the X-ray, because it is the direct implementation of the anatomy which you learn. So here is the coarctation. Right? Now this coarctation can occur because of the many reasons. Because of hypertension, because of some injury, infection, some anomalies. Whatever may be the reason, it has developed. So now there would be the back pressure, right? Upside back pressure. So this pressure has increased. The pressure is increased. This pressure would be transmitted to the subclavian artery. From there, that pressure will go on to the internal thoracic artery. And then from here, that pressure is going on to the anterior intercostal arteries. Right? Now, these intercostal arteries, they are here. Right? They are here, just underneath the rib. It is the artery which is pulsatile. Right? Veins, they are not pulsatile. So they are which are very weak, very thin walled. These arteries, they are, because they'll say, because we are directly connected with the aorta, right? So they pulse. And now because the pressure is more, so they'll be pulse. That pulse will be much powerful. So they will become pulsatile. Pulsatile. Right? Not only pulsatile, they will become tortuous, because less space, more blood is coming, so they become tortuous. Right? They become tortuous. So these are the pulsatile, tortuous intercostal arteries. Now, when they become tortuous, right? As far as when they are straight, so they are beating normally, right? Nothing happens. But when they are tortuous, so this is the rib. Right? This is the rib. And if the artery is normal, so that artery is like this, right? It is the whole artery is beating out. But when it has become tortuous, so that artery is now going something like this. And now it is beating. So it means that kink, that tortuous part, right? It is now hitting the inner surface of the rib, right? Inner surface of the rib. Are you getting it? Right? It will be hitting the inner lower surface, and then there would be a formation of notch. There would be formation of notch. This is what is called as the inferior rib notching. Inferior rib notching, right? So why inferior rib notching? Because of the tortuous pulsatile intercostal arteries. And which arteries we are talking about? We are talking about anterior intercostal arteries, because anterior intercostal arteries, they come from the internal thoracic, which is a branch of the subclavian artery, and that subclavian artery which is into the direct communication with the aorta. And this is the narrowing. When this thing occurs, see the X-ray, and you will see something which you never forget in your life. One of the finest representation of inferior rib notching. See, I'll zoom this thing. You try to compare that thing with a normal, right? Can you see? If this is the right hand, it is here. See here. See here. Here. See, then here though it is extensive. Here it is extensive. Now I'll remove all these lines and just put the arrows. Right? See the rib notch. Right? How it is. See this. Right? The artery is pushing this one. See this one. See this one. This is so classic. Just can't miss it. See here. And just zoom this. See this. This one. Now, when you'll see, this is normal. This is how it should really go. See, so smooth, right? See, so smooth, right? But over here, notch. This is the spot diagnosis. This is what is called as the spot diagnosis. You see it and you diagnose. This is where the diagnosis is. What patient of a So that's what is called as the. Because this question is such that if you diagnose it, and if you tell the reason, then there is nothing like it. And in case if it comes into your viva, then you just smash the interview. So that's it for today. Thank you so much. And once again, wish you a very happy Holi and lots of Ashirwad. Be very successful in your career as well as in your life. Be happy, stay healthy. Take care. See you soon. We'll be meeting now on Tuesday, right? Not on this Saturday. Take care. See you. Happy Diwali to all of you.